Yes, hello everyone. Are we more or less all there now? Okay, by halfway, right?
I see that we're with 30 right now, but we have like a total of around 60. So I think people are still coming.
Yeah.
There are still people actually at school. I think they're probably like watching together, like there.
Yes, that's the way it looks now. Quite interesting. All kind of bubbles are looking, watching it.
Yeah, we're all in groups now, sort of, because we had the offline class for the first time.
Yeah. Okay, oh, that's why. Yeah.
I think we can start, isn't it?
Okay. Well, hello everyone. For this second part of the webinar series of the Science Gallery and Willem de Kooning Academy collaboration. I'm Wiegertje Groenveld. I'm advisor to the Science Gallery in Rotterdam, and I've been there from the start. And I'm always very happy to see what kind of interesting things will come our way because of it. Science Gallery really brings together science, art, young people. We really work at the crossroads of these with these three groups, which makes it very interesting to see and help them work together, get insights into each other's way of thinking. And I hope we can bring forth more learning by exploring from all sides, and that everyone can, through the interaction, will be able to work further and get more insights, and will have interesting conversations. The Science Gallery, with the collaboration now with the lifestyle and transformation design, what we are doing now with this this series is also to get the students of the Willem de Kooning Academy to get us input for our new exhibition and our educational program for the for this year's exhibition about COVID and Corona. Yesterday we had a whole hour about more the pandemic and the real and these kind of the real virology issues. Today we will talk about things more the social impact of Corona and COVID. In that sense, we have three speakers. Juanita, she will talk about how public health care and is impacted, and how whether or not the inequity through the health politics is bigger or smaller. Jantien will then focus more on the smaller group and tell us about the effect of all the masks that we have, all the face shields, with communication to people that are have hearing loss or can't hear at all. And then Anna will help us and get another the artistical view of because of course, if you talk about Corona and society, you also have things like we all have to stay at home. Home is shelter, but is it a shelter? So we'll this way we have three quite different ways of looking at the social impact. So I'd like to give the floor to Juanita to start with her presentation.
Okay, thank you very much for your introduction. I'll just now share my screen. I hope can you see it? Yes? Okay, so hello, my name is Jonita Haagsma. I work at the Department of Public Health as an assistant professor at the Erasmus Medical Center. And one of the projects I'm currently involved is investigating the impact of Corona on inequity in the society. So public health, this is a term that I will use a lot in my presentation. So I'll just briefly say something about public health. What is public health actually? Well, it is the science of protecting and improving the health of people and the communities. And in this case, health is a very broad concept. It ranges from preventing disease to also improving quality of life and well-being of the general population. So actually of everybody in the population. Well, COVID has, of course, a big impact on public health. You probably already talked about this yesterday with the actual things about the pandemic itself. But until now, COVID-19 has resulted in an ongoing pandemic, and there is a direct impact on public health. So a lot of people get ill from COVID-19. At the moment, I think approximately 13% of the population in the Netherlands has been infected by COVID-19. And of course, most of these people had mild self-limiting symptoms. So maybe after a week or 2 weeks, they were healthy again. But also a lot of people suffer from more severe consequences of the COVID infection. For instance, going to the hospital and having long-term consequences of COVID, like the long COVID symptoms, like fatigue or respiratory problems. And of course, there were a lot of people who died from COVID-19. And this is the direct impact of COVID on public health. And with 13% of the population being infected, then you're talking about more than 1 million people in the Netherlands. So it's quite a big direct impact of COVID on population health. But there's also an indirect impact of COVID-19. For instance, people have psychological distress because of fear of infection. People have social isolation or experience psychological stress because of measures such as quarantine, social distancing, and also lockdown restrictions. There are also reports of more unhealthy behavior. So for instance, people smoke more during the COVID pandemic, and there's also an increase in weight and lower physical activities, also because the gyms are now closed. There's also economic uncertainty and job loss, which can affect the psychological distress or can cause psychological distress in the public health, in the general population. And there's a discontinuation of usual healthcare. And this is sometimes voluntary because people don't want to go, for instance, to the emergency department if they are injured or because of other health causes. I think the Erasmus MC emergency department showed already a very big decrease in visits to the emergency department, particularly during the first wave of the COVID-19 pandemic, but also an involuntary discontinuation because, for instance, operations were cancelled or some diagnostics were not available, so people couldn't have their cancer treated or diagnosed, which also leads to an impact of COVID-19. These are the indirect impacts of COVID-19. Of course, there are also vulnerable groups in the population. Not everybody in the population is affected similarly. And in previous research showed that particularly people with a lower education, people with chronic disease, so for instance, having long-term effects of disease, and this may be because of the discontinuation of care, but maybe also because of a higher perceived risk. So if they get ill, they may have a bigger chance of getting very severely ill or a higher chance of dying. And also vulnerable groups are young adults and older adults. So not everybody in the population is affected similarly in the population. So there is some inequality here. Another thing that is very interesting and that my research team particularly found very interesting was the effect of the stringency of the measures. There is an Oxford COVID-19 stringency tracker. This is a very complicated name to explain that not every country has the same severity of measures. Some countries have much less severe or stringent measures, like Sweden, for instance, compared to other countries. Here you can see a graph of the stringency in 6 countries: Italy, Spain, France, Germany, Great Britain, and Sweden. And also you can see on the bottom of the graph the weeks in which the stringency was measured. And for instance, at the last measurement moment, 22 April 2020, so this was last year, you can see that the stringency of the lockdown measures, so the government response against COVID-19, was much higher in Italy, which has the highest stringency. It runs from 0 to 100, and 100 is the most stringent. And here you can see that Italy had the highest stringency in 22 April, and Sweden has the lowest stringency. And there's quite a big difference in stringency of the government response per country. And we were very interested to see if this stringency had some effect on quality of life and well-being of the general population. So for this purpose, we performed the population health impact of the COVID-19 pandemic study, a very long name. We call it the popcorn study. And the purpose of the study was to assess the quality of life and mental well-being of the general population of 9 countries. And these 9 countries had a very ranged a lot in stringency of measures. So for instance, we included Sweden, but also Italy. And we measured in April 2020, so in the first wave of the COVID pandemic. We sent a lot of people an online survey, so more than 27,000 people received our survey. And we asked items, or we asked them about social demographics, so for instance, age, gender, educational level, but also their COVID-19 status, so if they were ill or not, or if they have been ill or not, their essential worker status, job loss, if they experience job loss, and also access to healthcare, and a lot of other variables. Very long questionnaire, so I'm very happy with the people who were actually completing the questionnaire. But this allowed us to study the impact of stringency and also if it had an effect on inequality. So is inequality bigger with higher stringency or the other way around? Well, the results can be summarized in these 2 graphs. They look maybe a little bit complicated if you're not used to looking at graphs. So I'll just discuss them briefly. Here you see 2 graphs. The first graph is for healthy people, so the left graph, and the right graph is of the diseased people. So we separated the people in those that were healthy on the one hand or had a disease, a chronic disease. These are not the people with COVID-19 because we had them out of the sample. For this graph, we did not show them. So we have healthy people and people with a chronic disease. And on the bottom of the graph, you see the age categories. So from 18 to 24, 30 to 34, 44 to 44. So these are the age categories. And on the y-axis, so going upwards, is the quality of life. And quality of life is a number between 0 and 1, where 0 is the worst quality of life and 1 is the best quality of life. And in this case, you see the colors also, and this is the stringency. So for instance, the purple line, these are the people, the healthy people who were in a country with quite a big stringency of COVID-19 measures. And for the healthy people, we don't see a lot of difference. We also don't see a lot of difference between age groups, but we also don't see a lot of difference in quality of life if it was a very stringent measure at the moment or not. But for the diseased people on the left side, you see that overall they have a much lower quality of life compared to the healthy, which is what you would expect, of course. You also don't see a lot of difference between age categories. So it doesn't matter if the people were old or younger, their quality of life was more or less the same. But you do see quite a big effect of the stringency. And the effect is particularly that the more stringent the measures were, the better the quality of life of these people. And of course, there are a lot of reasons we find this, which I don't know if I have time, but you can always ask about it. But it was quite surprising to me, because I expected that the higher the stringency, the worse the quality of life of people, because that's the general idea you get from the media, that people are very unhappy with all the measures. But this is quality of life. So quality of life includes also mobility, ability to do usual activities, ability to have self-care, etc. So maybe for mental well-being, we would see something else. So we also made this figure for mental well-being of these people. And the results you can see here. So again, on the left, you see the healthy people. On the right, you see the diseased people. On the bottom of the chart, you see again the age categories. But now on the y-axis, instead of quality of life, we see the mental well-being of the general population. And now you see that the diseased people have, of course, a lower mental well-being than healthy people, which is what we expected. But we also see that actually the stringency has an opposite effect. So the more stringent the measures are, the more impact on particularly the healthy people. Because here we see much more differentiation between the healthy people for the stringency. So this is actually an opposite effect of what we found before with the quality of life. The dotted charts that you see, because you look at the lines, but you see also some dotted, and that's the interquartile range, which gives some information about the range. And of course, you would expect that for the diseased people, there's more range in quality of life, so more difference among people with a disease in quality of life than among the healthy. But this is, I think, a very interesting way of looking at the role of the stringency of the measures, and if this has an effect on the general population, and particularly the vulnerable people, like the diseased people. Well, in conclusions, we found that, of course, I think everybody found that COVID-19 results in a new challenges in public health, but that the focus should not only be on COVID-19 people. We see that there are quite a number of vulnerable groups in the general population. You can imagine we have much more results than the few things I just showed you, but we find other vulnerable groups as well, and that stringency really plays a role in this. So there is a call for a broader perspective when you look at measures and the effect in the general population here. Well, this concludes my presentation, and I'll give the word back to Wiegertje. Thank you very much for your attention.
Thank you very much, Juanita. It's quite interesting to see that the health impact, the general health impact is quite opposite to expectation, but the mental impact is very different. I think that's also one of the big parts where there are big questions, and that's where people talk about what to do. So perhaps that's also for the students an interesting way of looking at their research later on. I would like now to give the word to Jantien and to see how the effect of the use of masks and people with hearing disabilities have, what kind of questions that brings to us. Jantien.
Thank you very much for the introduction. I will share my screen. Can you all see it? Okay. Thank you for the invitation to tell something about our project about hearing loss and the impact of face masks on patients with hearing loss. It's a project of my colleague Nienke Homans and myself. I'm working as an audiologist in the cochlear implant team in the Erasmus Medical Center. And before I tell more about our research project, I will tell you something about the cochlear implant, because we did our study with patients with cochlear implants. And therefore, I will take you back to your biology lessons about hearing in high school. As you may remember, sound is a little vibration of the air, which travels through the ear canal to the eardrum and is transmitted by the tiny bones over here to the cochlea. The cochlea is converting the signal to a electric signal, which is transported to your brains via the cochlear nerve, and then you hear the sounds. For people whose cochlea is not working at all or very worse working, a cochlear implant can be a solution to restore a part of the hearing. A cochlear implant consists of two parts, an outer part which looks like a normal hearing aid, which is converting the sound to an electric signal, which is passing it to the implant. And this tiny end of the implant consists of several electrodes, and it's placed into the cochlea. And with a cochlear implant, patients are able to hear. They're able to hear speech in quiet environments, but what's important to remember for the rest of the presentation, they still have a hearing loss and they're not hearing normal. When you compare normal hearing with a clear picture, you can compare hearing loss with a picture with a much lower resolution. And this is the thing for patients with cochlear implants. They have a much lower resolution of hearing. So they have to figure out what's said the whole day. And they don't have a clear picture of everything. And when face masks are introduced, it's even for us sometimes a problem when you are in the supermarket or you are in places with a lot of background noise. It's sometimes also for us a little bit difficult to understand. But for patients with hearing loss, it's a much larger problem. If you are normally not able to hear everything, with this face mask, it's much more difficult. And with the introduction of face masks in public places, all our patients came in with us complaining about the face mask. So we thought we have to do something. And we started with a first study where we developed a questionnaire, and we get response from more than 200 of our cochlear implant users. And the questionnaire was consisted of a lot of questions, but the most important things were that patients felt more lonely due to the face masks, that the quality of life was lower, and more than 80% of them experienced moderate to severe problems due to the use of the face masks. And then we were going on with the project in the Erasmus Medical Center. For clinicians, they can choose for face shields instead of a face mask to improve the communication with patients. So we were wondering if that's a better option for our patients. But from other studies, it was already shown that the face shields distort the sound a little bit. And again, for us, that's not that kind of problem. It's not that big problem, but maybe for our patients with hearing loss, also the distortion of sound can have a real impact. So the research question for the second part of this study was, what option will be the best for our patients with hearing loss? Will it be the face shield or the face mask? And we tested 42 of our patients. 23 of them were wearing a cochlear implant and 19 wearing a normal hearing aid, and all had hearing loss. And we tested them in 3 conditions, one without any device, one with a face shield, and one with a face mask. And sentences were read by speech and language therapists of our center, and they were wearing the mask, the face shield, or nothing during the test. We tested 2 things. At first, we tested the acoustic effects of the face shields and the masks with a sound level meter. And second, all our patients had to repeat the sentences of the speech and language therapist. And we checked how many of the sentences were repeated well. And then the results from the acoustic analysis are shown over here. The horizontal light line is a situation without a mask. Everything above is a louder sound. Everything under this line is a softer sound. And for the face face shield, you can see that for the low frequencies on the left side, the sound is even becoming louder due to the face shield. And for the higher frequencies, it's becoming a lot softer due to the face shield. For the face masks, it's a different story. For the lower and mid frequencies, it's almost the same as if you wouldn't wear a mask. But for the high frequencies, also the sound is becoming softer. But the impact of the sound of the face mask is much less than for the face shield. So then we checked the sentences of our patients. How could they respond to it? And then we found out that the situation with the face shield was the same as if no shield of mask was worn. So the patients were able to understand everything we said, although the distortion of the sound was much bigger than with the face mask. So this was probably compensated by the fact that they could see the face, that they could see the facial expressions, but most important, that they could make use of lip reading. However, for the face mask, a much worse speech perception was found. So people couldn't understand the sentences we said with the face mask. And that's a really important information for clinicians, but also for the general public, that if you communicate and you wear a face mask, it's not possible or not very good possible to communicate with people with hearing loss. And because our patients experience such a big problems in their daily life, we try to empower them, and my colleague developed some buttons and postcards to give to our patients, and with this they can talk to their family, friends, but also in the shops, that they don't understand if you use a face mask. And if you have any ideas how to empower our patients, how they can talk about it, or a good idea for a transparent face mask, we'll happy to know it. So let us know. Thank you very much for your attention.
Thank you very much, Jantien. It's interesting to see that although a face shield dampens also our voices, but by being to see what people are saying, that it's about almost the same as not wearing a mask. So I hope perhaps one of the students or student group can find you a new way of a new kind of mask. And then I'd like to go to Anna, our artist, who worked with art, data, and health, about her subject of shielding. Go ahead.
Thank you. I'll share the screen. Can you see that okay? Hope so. Okay. So I just got a quick overview of who I am and what I do. I work very much embedded in science, usually a lot with infectious diseases. But just before the pandemic, I was approached by the University of Brighton to do a project working with a local charity called RISE. They have a research project at the university called Art, Data, Health, which was trying to empower people to use their own healthcare data and to work with that. And the idea of the commission was originally that I would go and run workshops with, originally it started off to be, it's a charity that deals with victims of domestic violence or survivors of domestic violence, particularly women they focus on. And the initial idea was maybe to work with the survivors of domestic violence. Then it was kind of changed to be working with the staff, because there was some, like, I think there were some concerns about, whether it would be triggering to talk about it and things like that. And then the pandemic happened. So I wasn't able to run any workshops physically. This is literally March last year. And how would I alter and change this project and to make something happen? So I ended up thinking quite a lot about how to make this work. And at that time, a lot of newspaper stories started to come out, and they were talking about a third of women. There was a third increase of women reporting domestic violence during the early stages of the pandemic. And of course, this charity that I was working with, they were flat out. They were flat out with people calling them, because the home is supposed to be the safest place. It's supposed to be where we go. What they called it in the UK was shielding, where one of the earlier speakers was talking about the clinically vulnerable people staying at home and not going to the shops. They told them to shield for this extended period of time. I mean, they literally just ended the shielding now. So people have been shielding for a really long time. And so there was this idea of protecting them. In America, in the States, they call it sheltering in place, I think. So it's a different term. But it was this interesting term, shielding, that meant you would be protected by staying at home. And they would provide all this infrastructure for you to stay at home so you could be safe. But of course, if you're at home with a partner who's violent, then you're certainly not safe at home. And normally they would go out to seek help. They would be able to go out and make a phone call, perhaps. They would go to the shops, but you couldn't really go to the shops, or you could go to the supermarket, but very limited way. So there was this real lack of being able to escape. And I was reminded of Virginia Woolf's essay, A Room of One's Own. I live quite close to where she lived in Rodmell. I live in Brighton, on the south coast of England. And she wrote this amazing essay where she said that to be a writer, it's a very famous writer, to be a writer, a woman needed a room of her own with a lock on the door and £5 a year in income. And if you look at the essay, it's really fascinating. There's some interesting bits in it. I copied them onto my phone so I could read them to you. She said about women, she says, imaginatively, she is of the highest importance. Practically, she is completely insignificant. She pervades poetry from cover to cover, but is all but absent from history. She dominates the lives of kings and conquerors in fiction, but she is the slave of any boy whose parents forced a ring upon her finger. Some of the most inspired words, some of the most profound thoughts in literature fall from her lips, but in real life she could scarcely spell or hardly read, and was the property of her husband. And then later it said, the woman in fiction was like the greatest heroine in fiction written by men and things like this. The infinitely beautiful, hideous in the extreme, as great as a man, some think even greater. But in reality, she was locked up, beaten and flung about the room. So this is some of the points in this essay by Virginia Woolf. And this idea of the room of one's own became very important to me. And I was looking at all these photographs coming through from Wuhan in China of these temporary hospitals that were being built, these kind of vast temporary hospitals. And they were so fascinating visually. I know you shouldn't look at things like this from a visual perspective, but as an artist, you can't kind of help it, because they'd obviously done it in such a rapid period. They didn't have matching bedding. They'd obviously gone to the local factories and said, we need all the duvet covers you can get. And they were all different colors and things like that. And so this was this very striking image of this like sublime sea of beds with all these different colors on it. And I was thinking about sort of the feminine crafts and handicrafts as well, and this thing here. So tying all this in and tying in this figure of 30%, a third increase, all these papers, I started to collect them, and I was collecting every link I could get in newspapers of these stories coming out, and they were coming out from every different country in the world. Really strange stories about women who could not go out from their houses during the pandemic and were locked in with abusive partners. And I know it's a problem for men as well and for children, but the charity I was working with specifically focused on women, so that's why I'm thinking about that. And so I went back to Art Data Health and I said, look, I've got an idea that I could make an artwork that communicates this issue of the situation of women during the lockdown. And because there was this emergency response to COVID-19 with these buildings of these great big hospitals. We've built loads of temporary hospitals in huge concert venues here. They were never used, but they built these enormous hospitals. But this emergency response for these women was very slow. It's kind of happening, but it was very slow. And so we wanted to kind of use things like the artwork to raise awareness of this. So in my head, I'm thinking about the temporary hospitals, the images of that, and I'm thinking about Virginia Woolf's Room of One's Own. And then I was also thinking about Henrik Ibsen's play A Dollhouse, which is about women trying to find their way in the world as well. And this sort of playing with this idea of dollhouse furniture and this sort of, images. So what I did was I created a set of, at this point it's 30 beds, because the funding was limited for the commission. I would like to make a lot more if I could. And they're these little tiny beds there. Each one is based on the beds in Wuhan. So it's a 3D model, 3D printed bed. And then you've got the bedding, which replicates the bedding in Wuhan, but instead of the multicolored duvet covers and things, they've got these like little embroideries on. Now I haven't been able to I did send out a workshop thing, like activities to the charity, but we wanted to do a hands-on one. We still haven't been able to do that. But I'd love to, like when I extend the work, or if I get to extend the work, make it a participatory piece where other people actually make the embroideries with me. And then they tell stories of different things like shelter and different aspects of the pandemic in it. And they are impregnated with SARS-CoV-2 from a plasmid construct. So I often work with DNA, work with live bacteria or killed bacteria in my artworks. And in this case, and I find it gives this like sublime kind of quality, it's there, it's completely safe, DNA is non-infectious, but it's there. So it's got this trace of it in the thing, which I think creates a kind of power to it. I've got a piece on, if you happen to be able to travel to the Boerhaave Museum in Leiden, I've got a piece there at the moment that's called the plague dress, that's impregnated with plague DNA. And so it's a thing that I do. So the piece is impregnated with this SARS-CoV-2 from a plasmid construct, which was supplied by Jane Freeman and Inez Mora at the University of Leeds. And it's something they've been using in order to look for coronavirus in fecal samples. So for instance, they could be able to look for it in sewage or something like that and see whether a city was affected by the disease. So that's kind of how the work was brought together. And we managed to install it in a place called the Regency Townhouse in Brighton, which is a historic house. And this is their kind of still work in progress, but very visually appealing kitchen space, which seemed kind of relevant, although my choices of spaces were somewhat limited to do it. We had it booked for an actual exhibition. The university was quite risk averse and they were too scared to actually open to the public, although at the time it was legally allowed. So I photographed it, we made a video work about it. So there's some idea of scale and me kind of setting it up there. I also made another piece in the pandemic, which was more to do with real data, and that was real data about tuberculosis infection. And in this piece, which you can look at my website, I won't go into too many details, it's called Susceptible. It's about antibiotic resistance and tuberculosis. And one of the previous speakers was talking about these kind of what I call collateral effects of the pandemic. And one of them is that tuberculosis diagnosis has gone right down. People aren't diagnosing it and they're not treating it. And it kills about 1.5 million a year. So put that in kind of terms of how many the coronavirus pandemic's killing. This is every year it's been doing this. So it's a very important disease to work with. So I work with Oxford University on that. And just to finish briefly, a piece I've made called Ex Voto, which is people's stories. So it's on the other side. So the first one's to do with data, but working very abstractly with data because it wasn't there. Really, I didn't have the tangible data from the charity. The second one's very data driven. And this one is about stories. And sometimes you can do a lot with data, but the stories are what really affect people. And so this piece called Ex Voto is people's stories of infectious diseases and the treatment of them, and antibiotics and antibiotic resistance. And so I've made different versions of it. And in the lockdown, I made a set of votives that told the story of my experience of the lockdown and incorporated that. So you can see things like toilet rolls, which we ran out of here, and the famous British hero Captain Tom. I don't know if you saw him on the news, but he sort of became worldwide famous elderly man. Things about PPE, COVID toe, all sorts of strange stories that were coming out at the time. And these are on show, although it's not open to the public yet, in an exhibition called The Plague, which is at the Valkhof Museum in Nijmegen. So you can go and see them, and they're hung on a ribbon, which is dyed with turmeric. It's the full installation, but with these new votives in it, and also votives containing about the plague history and containing plague DNA. These ones have the SARS-CoV-2 from a plasmid impregnated in the ribbon that they're hung on. So if you want to go and walk under that, you can go and visit the Valkhof in Nijmegen. And so that's some of the credit information. As an artist, you also have to credit everyone. Very important. And that's if you want to get in touch. Thank you.
Thank you very much, Anna. It's always very interesting to see how storytelling, also using data or just basic stories, will also give a very new way of looking at things. It's quite impressive to see that there are a lot of illnesses that are there, or other problems, other things with vulnerable groups. I think one of the things that is a red thread at this work, this hour, is the fact that there are vulnerable groups and that their needs are not met. So I think that would be a really interesting thing also for the students to pick up and work with. Well, there's still a little bit of time, so I'd like to invite the students to ask questions.
Hi, I'm the chairman for today's questions, and I would like to ask a couple of general questions at first, and then I have 2 to 3 questions per each speaker who presented their work today. So the first general question that we wanted to ask was, how do you collect data on social inequality? Like, what are the methods that you use the most in this kind of data collecting act?
This question is directed at me, I think.
Yeah, I suppose it's
or for all of us.
Yeah, it's kind of like a who likes.
Oh, sorry. Oh, we shouldn't react yet. Oh, sorry.
Yeah, it doesn't matter. I suppose who feels that they would like to answer, they can answer, because these ones are general. So
Yeah, sorry, I'm not very familiar with the format yet.
Me neither.
Well, we collect data on inequalities in our study, we send a survey to a lot of people, and we collected data on certain variables that are associated with inequality. So for instance, we asked about educational level, which is often used as an indicator of lower socioeconomic status. And of course, lower socioeconomic status can then have an effect on inequalities. So people with certain characteristics have less quality of life or less mental well-being compared to other groups. And in our case, we looked at people with lower socioeconomic status, but also lower income, specific jobs or not having a job, people who are unable to work, and also disease. So that's how we viewed vulnerable groups and assessed inequality in health-related quality of life and mental well-being. I hope this answers at least part of the question.
Yeah, definitely. Then what would you say is the difference between social inequality in the West versus the rest of the world? Did you encounter any differences? And like, what are these measures that you basically just told me? Do you feel like are these the most important in our Western world that we know, or would you say these are used in the rest of the world?
Well, that's a very good point. In our study, we only included high-income countries, so countries like United States, Italy, Sweden. So that's important to know. Quality of life and mental well-being is a concept that is used around the world. And inequality is, of course, how you define it. You can also use the International Wealth Index, for instance, and this is an index of what people have available. Like, for instance, do you have concrete walls in your home? How many rooms are there in your home? Do you have access to, for instance, a toilet in your home? So these types of indicators can also be used, but in our study, we didn't use it yet. Maybe in future, if we also get funding to do this study in lower resource countries, we can introduce that also to measure inequalities in health. But the inequality or the health part is used in all the countries the same. So you use quality of life, or the instrument that we use, and also mental well-being. You can use that in every country in the world. Yes.
Thank you. And how can we influence politics and lawmaking as designers to change the dynamics of healthcare? I suppose this is a question for all three of you, but yeah.
Shall I have a go? I mean, I'm a mere artist, so I'm sort of in the similar camp to designers, but I was very struck by the fact that the solidarity, I don't know if it's probably going back a bit in history, but the when they had the revolution in Poland, the logo for the Solidarity group, which is a very famous logo, I don't know if you studied it, that a designer decided that he wanted to help with the revolution there and designed this logo, which became a worldwide phenomenon. So that they kind of ended up getting known far more than they would have otherwise because of this great bit of design. And I think sometimes that can really affect things. The visuals make things engaging. And I suppose with art installation, I try and you try and get the policy makers to kind of come to it and see it, and because it's about storytelling in the case of my work, and it these stories hopefully kind of engage people, and so it gives them a different side of it than they might otherwise have. So there's sort of two answers to that.
So you would say the role or how we can help is basically through being a kind of mediator?
Through doing whatever you do, I guess. I think in my case, I make art to tell stories, especially the stories about science and healthcare and issues and infectious diseases usually. I mean, this is like going right back for the last 20 years or so I've worked with infectious diseases. It's only recently become fashionable, but yeah, I mean, it's all sorts of ways. I mean, the thing is with art, it can be as you know, diverse as you like. So I wouldn't say there's one thing. As any means necessary, I guess, is what I would say.
I agree with Anna, and I also think that including art and also design is very important to keep this broad perspective on health problems as well, because I'm a researcher, I'm a psychologist by training, and I'm more of an epidemiologist, so I have a very narrow focus. And also just the presentation of Anna, but also of Jantien, which is more about design, opens my eyes to a broader perspective, which is also needed. Not only looking at the numbers, but also looking at the stories behind, like Anna pointed out with her artwork. The stories behind those numbers is very important to keep in mind. And I think that helps researchers, but it will also help policymakers to broaden their perspective. And yeah, I think it's very important.
Sorry. This is a funny one, but maybe we can get an answer. What is the reason, or what is the kind of origin of why do Dutch doctors prescribe less strong medication? We came to this question when we were coming up with the questions, that I don't come from the Netherlands, and many of us didn't, and we kind of agreed that once we came here, there's always like a kind of, unless it gets really bad, we kind of don't prescribe antibiotics, for example, that much. And we were just curious, like, where does this stem from actually? Was there some historical event, for example, or some campaign that in the Netherlands that explained that antibiotics are maybe harmful to the immune system? Or where does this come from? Or this kind of like...
I can have a go at that one for antibiotics. I mean, antibiotics resistance is a huge problem, and it's one of the main subjects of my work, because basically people take antibiotics when they're not needed, and you can't necessarily target the right antibiotics. That artwork that I showed that I didn't really talk about, called Susceptible, is about this groundbreaking research where the scientists that I work with at Oxford University have discovered that they studied the genomes of like 10,000 tuberculosis cases, and they grew them in the presence of 14 different antibiotics. And from that, now looking at if they can sequence the DNA of the TB, they can give the patient the right drug, which are the first 4 frontline drugs for TB to treat it. And it's the first time this research has ever been done. So it's the first time you could ever successfully infer what the treatment should be from the genome of the disease. So very rarely when you go to the doctors, they will, even if they ask for tests, you'd probably be waiting a while. I mean, it's coming where they'll be able to sequence the bacteria. If they could like scrape your throat and sequence it, it might come maybe in the next 10 years or something, but it doesn't exist at the moment. So they don't know that they're giving you the right antibiotic anyway. So most of the time you're much better off seeing if you're healthy enough and letting your immune system fight that infection, unless it's taken hold in such a way that your immune system can't fight it. Because there's this thing in the Hippocratic Oath, they say, but first do no harm. But almost all antibiotics do some kind of harm. They're affecting your gut microbiome, all sorts of things. So they do have an effect. They are very good and they're very important to take when you need them. But if you don't need them, and this is why they're very cautious about it, if you might get better without, then you're better off not taking them. So I mean, it's one of those things, so you need to rely on the sort of the medical advice there. Also, doctors tend to still overprescribe. And there was a study that showed that doctors maybe sometimes overprescribe about 50% with antibiotics, and like unnecessary prescribing of antibiotics when they don't need to, when you actually go into the study of it. Because each doctor's like working directly with their patient and want to make their patient happy. Patients put a lot of pressure onto the doctors to prescribe antibiotics when they're not needed, and all sorts of things. So they're probably doing it right in the Netherlands, or a bit better than a lot of places. It's almost impossible to get antibiotics in the UK unless you're kind of dying. so might be easier there.
So it's similar in England as well. Maybe because yeah, of course, it is. It's a very big issue, this overprescribing, but it was kind of interesting to us. Like, for example, I come from Czech Republic, and I wouldn't necessarily say that, of course, there is a lot of overprescribing, but I feel like when I had a lot more bad experiences where in the Netherlands, and I wasn't, when we have this discussion, that I wasn't the only one, that in the end, maybe it got so bad that then they prescribed antibiotics anyway. So in the Netherlands here, I mean. So so we were kind of wondering if there has been some kind of historical event or something that maybe if you can recall something that happened in the history of now UK and the Netherlands that maybe didn't happen in the rest of Europe that much.
I think that both the Netherlands and the UK are very leading in genomics research. So we do a lot of genomics research, and the genomics research is the stuff that shows how significant this antibiotic resistance issue is. And I think the UK press, and I think probably happened in the Netherlands as well, had a lot of publicity around antibiotic resistant infections like MRSA, MRSA, as they call it in America, and things like that. So we had a lot of scandal a few years ago about that, where they sort of put it down to dirty hospitals. And it turns out that a lot of the time it's not down to dirty hospitals, it's down to these bacteria picking up these antibiotic resistance genes and becoming, they're evolving basically. The more they're put in the presence of antibiotics, so the more you take them, and when you take antibiotics, like you go to the toilet, they go into the sewage system, so the bacteria in the sea are getting resistance and stuff like that. So it's all out there, and in agriculture it's a massive problem as well, especially in the States. In the United States, about 70% I think of animals are fed antibiotics as growth promoters on farms and things like that. So I think it's all around this, and probably because the Netherlands and the UK had, such a history in microbiology as well, because, the bacteria, as they were known as animalcules, were first observed in the Netherlands by Van Leeuwenhoek. And obviously antibiotics, penicillin was invented in the UK. So it's like maybe there's this stronger history. In fact, Alexander Fleming, who's one of who's the discoverer of penicillin, not creating the drug, but the discoverer of it, said, sort of foretold in his Nobel Prize winning speech that antibiotic resistance could be an issue and we should be careful of it. But I think the real crux is when genomics became possible, when we were able to sequence whole genomes so we could see it was actually happening. And so that was a change in the technology that made us able to see it. Mm-hmm. So you picked my favourite subject there, so I apologise for going on too long.
Thank you very much. Then I don't know how much time we have. Maybe I can slip in a couple more questions.
Officially, we're in our hour, but I think it's nice to have, if you have one question per speaker.
Yeah. So I have questions for Juanita. Do you see a correlation between the social inequality and worsening mental health in a pandemic, during a pandemic?
Well, that's actually something we don't know yet. We measured at the beginning of the pandemic, so in April 2020, we immediately started making our questionnaire and sending it to the people in the general population. But we will have a second wave of data collection this April. So we hope to start collecting data in 2 weeks of the same people, so we can follow these people over time and also see if their health-related quality of life and mental well-being, anxiety and depression have decreased or increased or stayed the same. And because we have all the information on risk factors, or those characteristics of the people, we can also investigate if there are certain protective factors or certain risk factors for having better or worse mental health. So we hope to answer that question in a couple of months.
Okay. Thank you. For Jantien, I have, what was your motivation to pursue audiology, and did the pandemic situation change it? Or
Sorry, I didn't hear the first part of your question.
yeah, what was your motivation to pursue, or why did you become interested in audiology, and did the pandemic situation change it?
Well, I studied at the Technical University in Eindhoven, and during my master's, I was only sitting behind the computer, and that was not what I did like so much. And that's why I was looking in the Netherlands to become an audiologist. You need to have a technical background, but then you are going on further for 4 years in a hospital. And I thought, then I can see more people, and also that you can make a little change or a big change in someone's life, and you see direct results of what you're doing. Was one of the things I like. I really did like before, but I also have I like to do research. And then you have to wait a little bit longer for you have your you see the results most of the time. So many of my research is very patient related. So I like to do projects with which I can help patients quite soon. And yeah, I'm always. When things happen with my patients, I'm always really aware of it, and I'm always thinking, how can we do something for it? So when the face mask started, we almost immediately developed a questionnaire when we saw how much impact they had for our patients.
Okay, thank you. And for Anna. How do you implement you were talking about impregnation of the certain what do you call it, genomes, or
the
no?
DNA? Yeah, maybe.
Yeah. So how do you where do you get it, and how do you actually like inoculate it, or how do you get it into the material that you want to impregnate?
Well, usually pre-pandemic, I would extract it from the organism myself in the lab. So I've spent I trained in fine art, but I've spent many years working hands-on in laboratory settings with infectious diseases scientists. So I work with the scientists to extract the stuff, or to grow. Sometimes I grow bacteria into textiles as well, or grow it into objects. And then I sterilize it, because I work with dangerous pathogens, so you have to sterilize it. DNA is sterile. DNA doesn't have any infectious elements in it. So for working with dangerous pathogens like tuberculosis, which is a category 3 organism, you can just work with the DNA. And so in the case of the SARS-CoV-2 RNA, which is from a plasmid, so it's a synthetic version of it, but it's grown in a plasmid. That was supplied by 2 collaborators. One of my longer term collaborators was able to send it to me. So it's non-infectious, it's not dangerous. So they were able to send it to me. And then it's as simple as I literally get a brush and dab it on in the relevant places. It's there, the trace is there, it's the actual stuff. And it's quite important to me that real thing is there, and you're kind of being confronted with it, but it's not dangerous to you. It just happens to still be there. There's like the historic trace of it.
Okay, thank you very much. I think all my questions have been answered, at least the main ones.
Well, thank you very much, Wessel. And I'd like to extend a very, very big thank you to Juanita, Jantien, and Anna for enlightening us and talking about the indirect social, mental, and physical effects of COVID. A crisis always brings challenges, but also chances. And it's really, we'll see what you will bring further into it. And I'm really looking forward to see what the students will bring to it. On the 24th of September, there will be the Night of the Researchers. It will be the start of our exhibition for this year. So we'll see the effects right then. Tomorrow there will be Trust in Science. Hope to see you again tomorrow. Thank you very much for being here and participating, and see you tomorrow. Bye-bye.
Thanks a lot.
Thank you.
Thanks.
Thank you so much.